Good morning. I'm going to present the results of a study that has been developed in the context of the EPAAC Work Package 6 about social inequalities in participation in cancer screening programs. Social inequalities in health are those differences in health systematic and socially produced, but also unfair and avoidable. These inequalities are related to different opportunities and resources available to individuals due to different social conditions. Therefore, social inequalities in cancer refer to health inequalities spanning the full cancer continuum, which result in unequal exposure to cancer risk factors, inequalities in participation in cancer screening programs, as well as in access to cancer treatments. This leads to inequalities in cancer incidence and mortality, generally placing the most underprivileged social strata at a disadvantage. Participation in cancer screening programs has proven to be one of the most highly rated strategies for reducing cancer mortality. In principle, organized cancer screening programs assure more equity in access in comparison with other health initiatives such as case funding or opportunistic screening. However, social inequalities in participation can still be observed in population-based programs. Consequently, following the European Union Council recommendation of increasing the participation rate in this type of programs, ensuring equal access, we purpose to answer the following questions. The first question is, what are the characteristics of research on social inequalities in participation in cancer screening programs in developed countries? We would like to know where and how the research has been performed and what determinants has been analyzed. The second question is, which social inequalities in participation in breast cancer screening have been identified in Europe? And the third one is, are the European breast cancer screening programs tackling social inequalities in participation? In order to answer the first question, a systematic review was performed, doing a descriptive analysis by abstracts of the articles published between January 2001 and June 2011 about social inequalities in participation in breast, colorectal and cervical cancer screening programs in developed countries. To answer the second question, we performed an in-depth analysis of the full articles identified in the systematic review published between January 2005 and June 2011, and related with the same topic, but in that case focusing in breast cancer screening in European context. And for the last question, a questionnaire was directed to the responsible of European state and/or regional breast cancer screening programs. Although for the second and third objective we have also results for colorectal and cervical cancer screening, in this presentation we are going to focus only in breast cancer. Regarding the first objective about the characteristics of the research on social inequalities in cancer screening, 2,358 studies were identified in the systematic review. In 49 of them, we were not able to access, and 1,610 were excluded because were not articles, didn't analyze social inequalities in participation, or were interventions or reviews. At the end, 699 articles were selected as valid for the study. As you can see in the figure, most of the valid articles are related to inequalities in access in breast cancer screening programs, followed by those that focus on colorectal cancer and finally in cervical cancer screening. With regards to where the research on that topic has been performed, the results show that the great majority of articles have been performed in North America and in Europe, representing 80% and 15% respectively. Most of the American studies were performed in the USA, and most of the European ones were performed in UK, followed by Spain and France, and by Italy and Netherlands. If we analyze how these articles have been performed, it can be seen that the majority of them, 80%, are quantitative studies, being the qualitative methodologies scantily represented. Regarding the scope of the studies, we can observe significant differences between Europe and North America. While the European articles focus on all the target population of the screening programs, North American ones focus on specific social vulnerable groups. If we observe, following the World Health Organization social determinants of health model, what determinants were included in the articles to analyze social inequalities, it can be highlighted, on one hand, that regarding structural determinants, the European articles mainly use territory and socioeconomic status as inequality axis, and the North American ones use mainly ethnic cultural group as inequality axis. On the other hand, regarding the intermediary determinants, the European studies focus on program organizational factors such as invitation systems and type of tests, and the North American ones focus on population perceptions, beliefs, and attitudes. If anybody wants to go in depth in the results of this first part of the study, a report has been uploaded in the EPAAC website. Going ahead into the second objective of this study, that is to know which social inequalities in participation in breast cancer screening programs have been identified in Europe, you can see in the table the compilation of the results of the in-depth analysis of the articles. On one hand, regarding the structural determinants, the results show that it has been identified that women with lower socioeconomic status, as for example, low social class, living in a high deprivation area, low educational level, and unemployment status, were less likely to participate in European breast cancer screening programs. Moreover, immigrant women and older age groups and women in a single cohabitation are in greater risk of non-participation. On the other hand, regarding the intermediary determinants, the most barriers identified to participate in breast screening were unhealthy lifestyle, such as sedentary lifestyle or unhealthy diet, gender factors, as not having husband's permission or family demands, and suffering from osteomuscular disease. At the same time, facilitators to participate have been identified, as for example, previous use of health services, previous participation in breast and cervical screening, and factors related to health system as being invited to undergo mammography and having physician referral. Finally, focusing on the last question about the interventions to tackle social inequalities in European breast cancer screening programs, we are going to present the results in maps. Until now, we have received questionnaires from 22 countries that are shown in this map. In blue, you can see the countries from which we have received the questionnaires that are organized at national level. And in spot blue, you can see the countries from which we have received several questionnaires since they are organized at regional level. The orange numbers represent the number of questionnaires we have received of the total regions of the country. In that case, we have mixed the results of every region in a single questionnaire in order to simplify the analysis. In gray, you can see the countries that we haven't received questionnaires. If your country is not represented and you would like to participate in the study, please contact me. Regarding the characteristics of the programs, 63% of the countries included in the study are population-based, 5% are opportunistic, and 32% mix both types of methodologies. Moreover, 95% of the programs are free of charge. With regard to the age interval European Union recommendation, 59% of the countries included in the study follow the 50-69 recommendation and are represented in the map in dark blue. On the other hand, 32% exceed the European Union recommendation and are represented in light blue. And finally, 9% doesn't reach the recommended age interval and are the red ones. The orange numbers represent the amount of regional programs that reach the represented level. For example, in Spain, 5 of 14 regional questionnaires received exceed the 8 recommendations. Regarding the coverage, 55% of the studied countries declared to have some social group not covered by the programs. In the map, you can see in dark blue those countries that did not declare any social group not covered, and in light blue, those who declared to have one or more social groups not covered. In order to identify which type of social groups are not covered, you can see in the map red triangles for immigrant women without residence permits, yellow circles for prisoners, and green triangles for women without health insurance. According to the participation rate, 29% of the countries included in the study achieved a desirable level of participation, that is to say, that reached equal or more than 75% participation rate, and are represented with the dark blue color. 14% reaching an acceptable level, that is equal or more than 70%, and are represented in lighter blue. And 57% of the countries do not reach the acceptable level and are represented in the lightest blue. The orange numbers mean the amount of regional programs that reach the represented level, as for example, in Denmark, 3 of 3 questionnaires received reached the desirable level. Regarding the analysis of the participation, 77% of the countries included in the study declare that the participation is monitored periodically by socioeconomic variables. In the map, the countries that declare not to analyze the participation are depicted in red. In light blue, we can see those countries that analyze the participation based only on age and/or territory variables. And in dark blue, we can see those countries that used, beside those variables, others like socioeconomic status, educational level, ethnicity, and others. Regarding the performance of specific studies to identify barriers and facilitators to participate, 68% of the countries declared have performed one or more specific studies in the map. In the map, we can see in red those countries that declare not to perform any study. In light blue, those who have performed studies focusing in all the target population, and in dark blue, those that focus not only in all the target population, but also in other scopes, like specific social groups, specific geographic areas, and/or health professionals. In spite of interventions carried out to tackle social inequalities in participation, 61% of the countries included in the study declare to have performed one or more interventions and are represented in blue. The countries in red did not declare any intervention. In order to identify in the map who are the target population of the interventions, those countries with interventions focusing on all the target population include a red triangle. Those who focus in ethnic minority groups or immigrant status include a yellow circle. Those addressed to a specific geographic area were represented in green triangle. And those directed to the low socioeconomic groups include a pink circle. Examples of interventions with a general approach, that is to say, that focus on all the target population, are direct invitation, flexibility in the appointment, mass media campaigns, and informed decision-making strategies. On the other hand, examples of interventions with targeted approach, that is to say, that focus on specific populations or areas, are targeted information materials adapted to different educational levels and languages, cultural adapted information campaigns directed to immigrants and ethnic groups, improvement accessibility for low socioeconomic women and those for living in rural areas, and health empowerment in high vulnerable areas. Regarding the social participation mechanisms, most of the countries have included strategies mainly based on information and participation. And regarding the intersectoral approach, only 55% have worked by this approach, mainly in collaboration with education, immigration, and social work sectors. The main conclusions are: from the systematic review about social inequalities in cancer screening participation in developed countries, we conclude that research on this subject is scarce in Europe and uses mainly a general approach. The in-depth analysis about European breast cancer studies shows evidence of social inequalities in participation in every social determinant of health. Results of the questionnaire about European breast cancer screening programs indicate that only 60% of the countries declared interventions to tackle social inequalities in participation. Moreover, the majority of these interventions applied a general approach. Following the World Health Organization recommendations, there is a need to complement this approach with interventions addressed to vulnerable populations with a targeted approach. Good practices identified in this study to tackle social inequalities in participation in cancer screening are: to systematically analyze participation by age, territory, socioeconomic level, and immigration status; to design informative material adapted to the needs of specific social groups; to develop social strategies to help empower vulnerable populations; and to enforce intersectoral interventions to reduce transversal barriers. It's widely accepted that European healthcare policies such as universal national health systems and population-based cancer screening programs promote equity. However, social inequalities exist in Europe, and in light of the current financial crisis and the budget cuts in social services, it's expected that these inequalities will increase even more. Therefore, it should be prioritized to promote studies to identify social inequalities in participation in cancer screening programs and to implement strategies to reduce the gap in cancer screening access. To everybody who have contributed to this study, thank you.